Hello again. This is Sebastian Sattui. I'm a rheumatologist at Pittsburgh, Pennsylvania, and today I will be sharing a couple of cases actually for um, a QD clinic. And these cases both have a bit of a similar kind of message to it, when always thinking that not every pain in a patient with PMR is PMR. So the first case was a 78-year-old female who was diagnosed with PMR by her primary care physician. And this patient, her presentation had been very classical based on what the records that I received, with clear stiffness, prolonged stiffness, shoulder and pelvic girdle pain, and a significant impact in her quality of in her daily activities and elevation of inflammatory markers, and then a very nice and brisk response to 20 milligrams of prednisone initially. This, while going down on the steroids, there were initially no issues, but when the patient got to a dose of around 10 milligrams daily, she started having significant pain in her left hip. Pain which she also reported to be associated to stiffness and limiting her daily activities, and initially felt similar to PMR pain. However, her shoulders that were not involved initially were not hurting, and her right hip was bothering some, but certainly was disproportionate. The left hip was the main issue. So in the initial concern of PMR, given that it felt like, smelled like similar, steroids were increased again to 20 milligrams daily. After a couple of days, there was no response in the symptoms whatsoever. After a couple of days of no response with 20 milligrams daily, and there are still the concern if this was PMR, the patient's steroids were increased to 30 milligrams daily, again with no improvement. At that point, there was the clinical picture was not clear, and she was referred to rheumatology to be seen and assessed. And again, there was no debate on the initial diagnosis of PMR, but clearly her symptoms this time were not significant. We're not really raising the concern for PMR. Unilateral, no involvement of the shoulder girdle, no response to even 30 milligrams of prednisone, which is usually above where we tend to we treat patients with PMR. And she had initially an X-ray that showed no signs of anything else or any fracture, just arthritis of her hips. But given the symptoms and the exam, particularly the pain more anteriorly to her hip, not laterally, pain with internal and some pain with internal and external rotation as well, an MRI was done, which showed a pelvic fracture. She had not had any trauma, but she was also hadn't had an DEXA in a few years, wasn't started on a bisphosphonate, and this was someone who had been on steroids for some time. Patient had osteoporosis and had a pelvic fracture, and at that point the decision was to keep going down on the steroids, given there was no evidence of PMR, and orthopedics assessed the patient with the decision to just manage conservatively. Fortunately, while going down and while disease being adequately controlled, steroids went down and fracture healed. The second case is a patient who was a 72-year-old who had a diagnosis of PMR 2 years back. And again, classical presentation, 72-year-old who presented with acute onset of shoulder and pelvic girdle symptoms, stiffness, elevated inflammatory markers, and a brisk response to steroids. She had some issues with the steroids, was not really happy with them, but they tapered them off, and in a matter of a year or so, she was discontinued of them. She never felt that she went back to her baseline, which I think was never really involved in physical therapy or any other activities. She's not necessarily an active person at baseline with regards to physical activity or exercises, but she felt that, well, okay, this is what I was dealt with. But then 6 months after that, pain came back, but pain came back worse on her right shoulder. Both shoulders, which again, she never felt that she went back to baseline initially after being tapered off. but she felt clear before and after when starting treatment. But now her right shoulder was bothering significantly. Well, again, both of them were, but it was disproportionate on the right side. There were no hip symptoms. There were no other constitutional symptoms. It was just persistent pain with stiffness just on the right side. Had an X-ray which did not show any abnormality except for mild arthritis. So the patient was seen in our office and they're concerned of like, is this PMR again? And her inflammatory markers were normal, not that, as we know, necessarily excluded, but this was a patient who was 6 months off treatment as well, but had persistent symptoms, and she was very limited on particularly in her right shoulder, which was a dominant hand. So in that scenario, especially because the lack of evidence of inflammatory disease was on the lower side. And there were typical features to her presentation, an X-ray, and an X-ray had not shown necessarily anything. Her exam did raise a concern for some rotator cuff disease, but at that point, the decision was to get an MRI. And what the MRI showed was it did not show any bursitis, didn't show any acute tendinitis, but showed a high-grade partial thickness or tearing of the subscapularis, also some high-grade partial thickness tear of the supra and infraspinatus, some labral disease as well, and some mild tendinosis. There were no real inflammatory features. These findings on MRI were way more pronounced on the right side. Again, the full thickness tear of the subscapularis and the high-grade partial thickness tear of the other components of the rotator cuff were actually on the right side as well. And without any other inflammatory findings, neither on her history, neither on her inflammatory markers, and neither on her MRI, the decision was to treat symptomatically, to send for physical therapy, also assess my orthopedics, and the decision was again to proceed conservatively and without any concern for active disease. We have kind of touched a little bit on base of like one, the scenarios where imaging is important. We know that, and we have heard about this, that both ultrasound, both MRIs, and nowadays also PET scans can be useful for the diagnosis of PMR. The role in monitoring is still not established yet, but it's also important because it can allow us to better assess the patient and rule out any other causes, because not everything that hurts is PMR. Whether it's a fracture, whether it's some other kind of soft tissue condition that can be leading or mimicking symptoms. Again, the other feature that was also common between those two patients was the asymmetry and some, again, not the classical picture that we were concerned for a relapse of disease in patients with PMR. So I hope you've enjoyed both of these cases, and thank you again for listening.